everyone. You're listening to Let's Psyconnect, and this is LT. In today's episode, I'm going to focus on chronic pain and mental health, but more specifically, what research has shown to be associated with chronic pain and mental health. So, some considerations for mental health professionals and other professionals to you know keep in mind, be aware of, because it can influence treatment, right? But before I get to that, you can also watch today's episode. The episode is going to be available on Instagram as well as YouTube. You can go to letspsyconnect.com, go to podcast episode link, and then you're going to scroll through the page and find chronic pain and mental health episodes over there. Or go to Instagram. The handle is Let's Psyconnect, and you have the link for the IGTV series page as well as the link to YouTube. All right. Before I get started, I also want to say that I'm not an expert in pain or in any of the subjects that I've been talking so far here on my podcast. I am passionate about pain, like I've mentioned, in different episodes. And I have done some fair amount of reading on chronic pain, and I'm going to continue to read more about chronic pain and hopefully start being part of some research projects that also look at chronic pain. And chronic pain, as I mentioned in previous episodes, it affects millions of people, adults, around the world and here in the US. It also affects children and teenagers. But like I said in the previous episode, I'm going to be focusing more on what regards the experience of adults, because that's the population that I work with, and so I focus my training on that population. But nevertheless, some of the materials discussed here can be references to the treatment provided to children and teenagers, but you should definitely look at the research and what has been found to be associated with children and teenagers when it comes to chronic pain. So you're better informed, and you can also better provide you can provide a better treatment to your clientele. All right, so let's get started. So last episode, I talked about chronic pain, so non-malignant chronic pain, also the biomedical model. I talked about the cycle of pain and implications to treatment. And I wanted to talk more in depth about some of the variables associated with chronic pain. And those variables, they're very much in alliance or in accordance with the biopsychosocial model or spiritual model. Because those variables, are part of it, like they're going to be either biological or psychological, right? Cognitive, affective, but also social and spiritual factors that that's important for us to be aware of. So some of the factors that research has looked at, who tends to report or experience chronic pain more often, right? Or what's the population out there? What does that look like? So if you're thinking about men and women, and so I know that research needs to look at it in a different way now. About in the past, so it has looked at it's either women or men or they're both experience it the same way. So far, more women have been associated with the experience of chronic pain, so that it be because of endorsement of chronic pain or reporting the chronic pain type of experience in comparison to men. But that can be due to various factors, right? Men might not be expressing as much as women do, and that can be influenced by cultural practices and whatnot. But we do know that women right now, that women are the ones that are highly associated with the experience of chronic pain. We also see that older adults are more likely to report or endorse the experience of chronic pain than younger adults. But that's not to say, again, that younger adults don't experience. They do. It's just we're more likely to see older adults diagnosed with and also experiencing and coping with chronic pain. And with that, it's important that we keep in mind that the older someone is, the greater the likelihood for medication misuse, and also the presence of other medical conditions as well as psychiatric conditions to be present in addition to chronic pain. So when research looked at a socioeconomic status, it showed that those in lower socioeconomic status are more likely to report or experience chronic pain versus those who were in a higher socioeconomic status. And when we go to race ethnicity, so far research has talked about, or the research that I came across at least, it talks about African American versus non-Hispanic white. So it seems that African Americans are more likely to experience and be associated with chronic pain than non-Hispanic white folks. And it can be due to a complexity of factors. One of the things that they talked about is the African Americans, they are more likely to be more expressive, like they show more of the emotions than non-Hispanic white. And they also more likely to be diagnosed with depressive mood, which seems to be associated with pain. Also associated with passive coping strategies. And they endorse higher levels of pain in terms of severity than non-Hispanic white. So something to keep in mind. There was one study that I came across that I thought it was interesting, that it focused on the experience of chronic pain of Iranian women. They said that it showed that basically the experience is associated with a lack of knowledge about pain, so that they put in the relief of pain on the hands of the medical providers. So meaning like the control is on them, the local locus of control is lower. And also when it comes to social pressure, so they're responsible for several duties in their house and within their culture. And so they believe, so that it seems to be associated with the experience of chronic pain, or it can be influencing their chronic pain. One thing that I wanted to also talk about when it comes to older adults, so to keep in mind of like some environmental factors that can be influencing their pain. So let's say like light, it can influence one's pain, and the older adults have shown to be more sensitive to light than younger adults. So if you're like in an office setting, making sure or adjusting the light, as well as temperature, and if you have any control around the noise, because those factors can also influence one's pain experience, and more likely to influence the pain experience of older adults. But it's always good to check in, if on younger adults too, if those factors are interfering with the experience while they are in your office, right? So social support, remember the cycle of pain. So as part of the cycle of pain, so individuals talk about, or they report that there's some loss of social support. So the individuals of chronic pain, so what I want to say here is that individuals of chronic pain, they perceive that their lives as impoverished and confined. That was something that was brought on the paper by Toy, Sears, Hamnick, and Barker, and that was published in 2017. And that impoverished and confined type of experience, is the result of the daily pain experience. And the fact that they're then unemployed, right? They're no longer employed. They no longer have that type of connection with other people, so like co-workers and whatnot. They see themselves even more isolated. They also believe or perceive that there's a loss of credibility, and that is again associated with their pain experience. And they tend to keep their experiences to themselves. And the mental health symptoms that they experience can lead to more isolation and vice versa. So it has a great impact on one's social support system, or the experience that they have of the social network, from before pain to after pain. And those who do perceive and still are able to maintain that level of support, including friends, partners, as well as other relationship, even with the treatment team, they they perceive that there is an improvement in their symptoms, and that the treatment and as well the symptoms improve, I should say. So like I said, it has a huge impact. So by maintaining that social support and also engaging in treatment with providers that show levels of support that are collaborative, it can actually positively influence one's experience in their treatment. So chronic pain is highly comorbid with substance use and substance use disorders. There's a greater likelihood for the occurrence of chronic pain and substance use disorders in clinical settings than in the general population. And the risk of developing substance use abuse is greater in it's greater in the first 5 years of experiencing chronic pain than in other times of their lives. And it's very hard to know exactly what came first, was the pain or substance use disorder. Some are able to report what came first, but not everyone is able to. But nevertheless, there are studies talking about, how using medication or using some type of substance use can lead to changes in the brain or physiology and whatnot that is associated with pain experience and lead to chronic pain. The presence of there's a study that talks about the presence of alcohol and other psychiatric conditions that increases the concern for suicidal behavior. And I mentioned that it's hard to describe which one came first, right? But those folks that are diagnosed or being in treatment for substance use disorder, they also have a hard time describing pain experience in general. So pay attention to that, because it might not be something that they will deliberately be able to just say, hey, yeah, I have chronic pain and whatnot, and how to describe, be very detailed about that chronic pain. It can be very hard for them for a number of factors, and it's unclear why. But like I said, there are different factors that might help explain that. So establishing a good line, a good rapport of communication, and paying attention to the communication that's been expressed. So what it is that they're talking about, so that you can make the connection or help make that connection and help conceptualize that the patient, or the individual in front of you. So it's not only substance use disorder that is comorbid with chronic pain. There are a variety of mental and physical health conditions, and I think it's important for us to learn about some of them, be aware of them, and how they can negatively or positively influence, well, in this case, negatively influence the development or maintenance of chronic pain. So patients of chronic pain, they're also more likely to experience depressive, anxiety, or post-traumatic stress symptoms than in the general population. So keeping that in mind, and there's a bi-directional relationship here. There's a lot of research out there talking about PTSD or trauma experience, not necessarily PTSD, and how when untreated, it can change the physiology of the person, and the trauma can be shown as pain. And so it's important to pay attention, because the pain can be untreated, right? Traumatic experience, or it can be alerting that there is some traumatic experience in the past or current. And like I said, there's a comorbidity between chronic pain as well as depression and anxiety. So patients with chronic pain who also experience depression and or anxiety, they are more likely to report worsening in pain and pain-related disability. So when we start adding to the layers of chronic pain, right, when we start seeing the depression and or anxiety, they are more likely to report, or we're going to see a presentation where there's the report of worsening pain when those symptoms are present. And they're also more likely to to exhibit a pain-related disability or avoidance behavior that leads to disability. And the other way around is also true. So those suffering from depression-related symptoms have greater chances for suffering from chronic pain. So again, paying attention. So if you have an individual in front of you who is experiencing or being treated for depression, I think it's important to assess for pain, not just during the intake or the first session ever, but throughout the treatment, because they are likely to report or report pain later on as well. Older individuals, they're more likely to report depressive symptoms, and that is associated with chronic pain. So keeping that in mind, right? And so patients suffering from depression may perceive the pain more easily than patients without depression. So in 2010, so Googlia, I might be mispronouncing that, and I'm sorry, Salvi, Mina, Rosetto, and Googlia, in 2010, they published a paper that talked about 90% of fibromyalgia patients reporting depressive symptoms, so 90%. So if you have a patient in front of you who has depression, so asking about or doing a chart review regarding pain and chronic pain conditions, including fibromyalgia, or if you do have a patient that is suffering from fibromyalgia, to assess for depression-related symptoms. Interpersonal or personal psychological factors. And so talking about it, right, cognitive factors or factors that can influence our relationship with other people, and also the way that we go about treatment. And there's a list of variables associated with chronic pain. I'm going to talk about self-efficacy and catastrophizing alexithymia. So self-efficacy is the strongest mediator of the pain experience and a predictor of to unemployment and disability. So assessing for self-efficacy, it's important, right? It can tell us a lot about pain, the pain experience, and how they're going about the treatment, all right? How they're doing things at home and whatnot, like if they feel like they can do anything about their treatment. So self-efficacy basically relates to an individual's set of expectations and beliefs regarding whether they can accomplish the desired outcome. So in the case of individuals with chronic pain, self-efficacy refers to whether an individual can engage in behaviors that will reduce their pain experience and lead to a better quality of life. So individuals with a weak sense of self-efficacy, then they are less likely to engage in behaviors that will help them tolerate and alleviate pain. So the other factor that I want to talk about briefly here is catastrophizing or pain catastrophizing, or the rumination about and magnification of pain, which refers to an individual's negative thoughts and expectations regarding to pain. So pain catastrophizing is related to pain-related disability, psychological stress, and influences pain measurement responses. So there's a measure out there for pain catastrophizing scale. Well, that's the name of the scale anyways. So to help assess for pain catastrophizing. And lastly, I've said that I was going to talk about alexithymia. So chronic pain has been positively associated with alexithymia, which refers to one's lack of ability to recognize and express their own feelings. So remember when I said that substance use, those struggling with substance use, they have difficulties expressing or describing their pain experience. It can be because of alexithymia. So assessing for alexithymia, I think it is important. Something that keeping in mind, and I don't think it's often talked about in the field of mental health, or we don't talk about it in training, I guess. If you did, and if you do, that's great. I'm glad you do it. Lastly, I want to bring attention to some of the physical health comorbidities. So I mentioned in the other episode that chronic pain often comes, more than one conditions. So let it be low back pain and migraine, right? And that can make things more difficult. They're more likely to endure symptoms associated with other medical conditions than the general population. And think about like insomnia, how pain can influence sleep, and vice versa. Also hypertension and different forms of lung problems, cardiac diseases, obesity, diabetes, also autoimmune diseases, chronic fatigue, and irritable bowel syndrome. Okay, that list does not encompass all of them, but it's just to bring attention to some of them. And so when treating folks for, let's say, insomnia or sleep difficulties, keeping in mind that they might be experiencing pain, or if they're experiencing pain, also to assess for sleep, and so on and so forth. And beliefs and past experiences, I also alluded to in the previous episode too. So it's important to assess what it is that they believe about their pain experience and the treatment that they're receiving, as well as the treatment team. There's research out there that talks about patients' beliefs. So patients believe that their physicians and others do not believe their pain is real. So can you imagine when they're sent to a mental health professional and they say like it's on my head, which is not true. So psychotherapy can't help treat their physical pain while I'm here. So they believe that they also believe that they will not receive adequate treatment. If they don't receive adequate treatment, there's lack of availability of treatment, communication difficulties. It's hard for me to express my feelings, right? It's hard for me to express, let's say, my pain experiences. It's going to be really hard for the provider to understand what it is that's going on, whether they perceive that they don't understand what's going on with that individual. With them, they're not included in their treatment plan. So again, it enhances the importance here of doing a collaborative approach and getting the patient or the client involved in the treatment plan. And I mentioned the lack of social support, or perceiving that there's a lack of social support, in addition to the loss of credibility within their social support system, and they struggle with seeking help. Actually, there's one more thing that I want to talk about. So there's a lot of there are a lot of pain measurements out there, and there's this belief that their pain. So patients report that there's this belief that their pain could effectively be assessed through these measures, and there's a difficulty in identifying an average rate as well as a specific rate that would reflect their pain experience. So there's confusion and lack of understanding regarding what pain really means and what to use as a comparison to their pain when they need to rate their pain experience. So it's important to be familiar with the pain measures out there and what they assess and what not, and when communicating the results to the treatment team as well as to the patient, to clarify what it's being assessed and what it might mean for that treatment plan. All right, so I hope you enjoyed today's episode, and I hope you stay Psyconnected. Go to Instagram as well as YouTube, and my website, letspsyconnect.com. And remember, let's Psyconnect.